for early detection of breast cancer, not other diseases. So this is an important issue to make a talk like this. Thank you very much.
Assalamu alaikum. First of all, I want to thank you all, my colleagues and my dear professor, to still staying with us after this very long day. And I want to thank especially Dr. Rasha. She gave me this chance to be a part of this great meeting. And for Dr. Ameret, you make it very difficult for me after this nice presentation. My presentation is overlapped by many other presentations before me, so I will try to make it fast. I know everyone is tired. By the end of this presentation, I hope dear radiologists to pay meticulous attention to mammographic technique and positioning, develop a standard search pattern, and always compare the current examination to multiple prior study when available. Everyone knows that mammography is the standard of care for screening the detection of breast cancer. However, approximately 10 to 30% of breast cancer can be missed by mammogram only. Multiple factors contribute this missed breast cancer at mammography. Some factors depend on the patient. She is having a dense breast, or depend on the technologist, suboptimal positioning, and other factors depend on the radiologist himself, that he is doing interpretation error. So we'll start to take one by one and try to solve this. Dense breast decrease the ability to detect a lesion, especially a non-calcified and a non-distorting lesion. This is an example of very dense breast, ACRD, and nothing you can see in this, of course, but when you did ultrasound, nicely you can find this simple cyst. So any patient with dense breast parenchyma, and even without any palpable mass, that we are see this in screening program, or they have a palpable mass with negative mammographic finding, should undergo ultrasound, then MRI for further evaluation of the mass. That's why any dense breast, we can solve this problem. But regarding the technologist, everyone had to teach his technologist how he is making a optimal positioning. So what is the optimal positioning? You will accept to write your report. You have fulfilled all these criteria. You had to see the convex appearing of pectoralis major muscle at the level of the posterior nape line on the mediolateral oblique view. The difference in the measurement of posterior nape line in craniocaudal and mediolateral view has to be less than or equal to 1 centimeter. Nape had to be seen in the profile. Also, it had to be in the center, not medially or laterally exaggerated. And tissue had to be well compressed, and this is very important. Inframammary fold open in mediolateral view. We will see how we put our film to report. No, first we will apply what we see on this mammogram. Convex border of the mediolateral view had to be seen. The measurement, a difference between the nipple, posterior nipple line in the craniocaudal compared to mediolateral has to be 1 centimeter or less. Nipple had to be in the center, had to be not rotated either up or down, and inframammary fold had to be seen open in the mediolateral view. Also, we had to put our mammographic view side to side, right craniocaudal to left craniocaudal, MLO right to the left, because we were making a mirror image of each other. Now we will have example for bad positioning. If you have this craniocaudal, you will agree to report on this report in this view? I think no. You will ask your technician, please, again, repeat this view. Why? This is the one after we repeat. You can spot the change. What is the difference between these two craniocaudal? This one is, the tissue is not well compressed like this one. And the nipple also. Here you can see the nipple in the center, and in the profile here, no. When you correct the position, you can spot this subtle cancer, it will be missed. But when you make a proper position, I think everyone can see this mass speculated. Okay, again, another example. If you have this view, you will accept to report in this craniocaudal? Of course not. Why? Because where is the nipple? You can see the nipple here? No, you will see the nipple in the center, and maybe you mistake this is a mass. But when you correct the position, you will see now very clearly thickening of the retroareolar area and this speculated retroareolar mass. That's why very important to be sure that your view is good positioning. Now the nipple must be in the profile, at least at one view, to enable proper visualization of the nipple and the areolar complex, and to avoid mistaking the nipple from the mass. Again, another example. If you have this craniocaudal view, you will agree to report again. If you say, I will report, I will show this one. I will not report. Why? Because this is the nipple, it is up. It is not in the center. But when you put the nipple in the center, now I think all of us can appreciate this mass in the lateral aspect of the breast. So please always keep your eye on the proper position of your films. Again, this is example for one lady with post-operative management of left lumpectomy. And after we repeat the position, and we can see nicely, as much as we can, the pectoralis muscle, now this lesion is now seen clearly. If we depend in this view, I think we will, of course, we will miss this lesion. So please, proper positioning is the key to ensure the most tissue is included on the mammogram. If the positioning is technically inadequate, of course, cancer can be easily missed. Now, again, our factor, the one depends on the patient, like denser parenchyma, and we know how to deal with it. Suboptimal positioning, the factor depends on the technologist, and now how we know what is the optimal position. And now the factor related to our dear radiologist, interpretation error. Why we make this interpretation error? Interpretation error because first, we have a lack of systemic approach, and this is very important. Second, fatigue. Third, the failure to obtain all the views and slow growing lesion. I will try to go through this problem and we will try to solve it. So how we can make a good systemic approach? By developing a standard search algorithm. Standard search algorithm, there is 7 checkpoints we had to check every time when we are reading our mammogram. First, anterior and posterior fat glandular interface, retroglandular fat, lower and inner triangles, edge of the image, axilla and axillary tail, and nipple areolar complex, and skin. I think all of this, Dr. Mike gave a very nice example. We will take example for this case. This is craniocaudal and mediolateral of one patient, and we can see after in 2022, we will see the difference. You can spot the changes. Yes, you are right. You are scared. Yes, this is the one you make your finger. This is the change. The change, this one. So if I am not, if you compare this with this, you found something here. There is asymmetry. If I am not following my systemic approach, I will miss. Why? This is very important area. The relation between the fat and the glands in the posterior area had to be checked every time. Okay, this is another example. Can one spot the change? Yes. If you follow systemic way of reading and always draw this line between the glands and the fat, at that time you can notice the change. You can notice this lesion. Maybe if you look at without this, you can miss it. This is the most common site for cancer. And here it is bitomo. This is infiltrating ductal carcinoma. Again, this is another example. Can anyone see where is the cancer? Where? Right side outer? Okay. If we will follow the way and we draw our line, now, you think where is the cancer? Yes. Yes. This is the scalloping margin, anterior, the relation between the gland and the fat. But look here, what is this hump? So this is the mediolateral oblique of the same case, and how it appeared in ultrasound. It was infiltrating ductal carcinoma. So subtle change in the contour along the posterior or anterior fat interface can be easily overlooked. Second checkpoint, and very important, is the retroglandular fat, lower triangle, inner triangle. Every time you had to be sure that you check this area. This is very difficult case. Anyone can notice? Lower, inner or outer? There is no lower, inner or outer? Okay, it is very difficult. It is here. It is here. That's why this area, suppose we will not see anything except glands, fat, and muscle. So, lesion within the retroglandular fat and lower and inner triangle had suspicious findings. Any tissue density should raise the concern and to be further evaluated. So only muscle and fat should be seen in this area. Again, another case. What is the de novo between this MLO and this MLO? Just remember the checkpoints. If you go through the checkpoint, you will notice there is small lymph nodes. In spite this lymph node is very small, but you look, all the criteria, you hear it from all our colleagues, we'll see here. Here, there is irregular cortex, thickened cortex, and there is a small calcific foci. So, whatever the size of the lymph node, it is not important. The important is it is newly seen, how is the cortex thickening is, and sometimes calcific foci is very important. So this node had to be biopsied. Again, another example. Where is the change? Again, we will checklist again. Yes, retroareolar. This is, if you always go systematic, like our professor they teach us about how to read chest X-ray, either from outside to inside or from inside to outside. Also, you had to make your specific algorithm for everyone to check all these points, because this is the points where the area where the cancer is always hidden. After we make a standard search pattern, we have a problem, I think all of us have, is the fatigue. Please don't report or read mammogram when you are fatigued, because easily you will miss many lesions. So how to solve this problem? Please, please, second reader is very important. Don't work when you are exhausted. And always ask for second reader. Especially if you are doing screening and you see a lot of cases, there is second reader is very important. I will give you some example from my practice. This patient came for me from outside. I am not the one who put the clip. They asking to put a wire because her OR is tomorrow. We are not putting our wire in the same day of operation. Sometimes you are putting the wire day before. And I am ready to put the wire. I am totally satisfied. And then one of my colleague come to me, say, Dr. Aml, it is something is, you had to look it again. Look again. Then when I look nicely, I saw this. I don't know, it is clear with you that all the area full of microcalcification up to the nipple. It is not seen. And also when I see it for the second time, I not appreciate this microcalcification until my friend came and say, no, have a look. There is a microcalcification. Then I called her surgeon. I told him the lesion, the microcalcification is not seen in the first time. They treat it as single lesion, put the clip, and no one take a look for this microcalcification. And he decided to change it from conservative to mastectomy. So please don't read when you are tired. Failure to obtain all the views, this is very important. Every radiologist has to know what the other view he will ask his technology to do. Very important, ask for other additional view, and you know what view to ask and for whom patient to ask for this view. There is why I will ask for additional view, why I am not taking craniocaudal and mediolateral and that's it, because there is to show specific component of anatomy not seen by standard views and to provide localization of the area of concern. This is too much extra view, additional view we will ask for, and I will show one example to you. This case, you will be happy, this a good craniocaudal, the nipple is seen, and also it is in the center. But the patient, as Dr. Ameret is telling, I can report this nicely, it is completely free. But the patient, because we had to ask for what is your problem? We had to have an examination for the patient and taking a complete history. The patient is telling, I feel there is something in my breast. Then I asked to repeat this with exaggerated craniocaudal view, and now this is the lesion. So it is very important to do which view I will do. I will do lateral CC view, exaggeration, or medial. I will do cleavage view to see the medial problem in this area, or I will do a spot film. This case also, if you see this film alone, I think sometimes we may say maybe the intramammary nodes, maybe. But when we ask, please make a spot film, I think you agree this is what, intramammary node? Or, by the way, this case, before I came here, I have no idea about the biopsy. I took a biopsy, but I don't know the result. But I think it is very suspicious. But if you, in the screening program, and you see this, you accept this, or you make magnified view or spot view. It is very important to know what view additional you will ask. This case came to me already. This is the same Dr. Ameret was telling us about the connection and interpretation between the radiologist and the histopathologist and the doctor. This case already by RAD6, and there is a speculated lesion, everyone know it. But the problem is, and it is proved as infiltrating ductal carcinoma, the problem is the doctor is telling me the pathology is coming as there is microcalcification in the spacement, in the true cut biopsy. And the report of mammogram is not reporting there is any microcalcification. So we feel maybe there is something wrong. This is her true cut, or it is something wrong. So please re-evaluate, review, and be sure there is no microcalcification. When the patient is come to me, I look for the film, it's okay, I couldn't see any microcalcification. I took my lens, I see there is no microcalcification. Then I ask her to go and make view with spot magnification. And it helped or not? There is, after spot magnification, we can see this microcalcification. So I told him, this is the same patient. There is really microcalcification, because always we can see microcalcification in the radiology, and the histopathology is say in the report, he is not mentioned anything about the microcalcification. But when the reverses happen, he feels there is something wrong. I want to be sure there is microcalcification in this patient. Again, the most always problem with us when the lesion is growing very small. If we don't have the previous imaging, I think it is very difficult to detect. Always compare the current examination to all prior studies. This is one of my patients. There is something here. Yes, you agree or not? But I missed it here. It was there, but I missed it. Again, I missed it in the screening. But here, with comparison, I say there is something. And by ultrasound, it's very clear it is ductal papilloma with carcinoma in situ. Again, this is one lady. She is doing her screen every year, but by 2020, this de novo. I think it is difficult. You have to make magnified view to this microcalcification. There is any progression in anything in this? This intramammary node, it is intramammary node. But later on, after 2 years, you can see it is increased in size, and there is some developed lesion. So very important to compare your studies. Now, by the end, the mammography signs of breast cancer can be very subtle. Please keep these tips in mind to decrease the interpretation error. Evaluate the positioning, maintain a standard search pattern, and compare current mammography to prior examination. Thank you. Hope to see you in Alexandria.